Okay, so the title of the study that I had done was Interactive Book Reading to Accelerate Word Learning by Kindergarten Children with Specific Language Impairment, Identifying an Adequate Intensity and Variation in Treatment Response. So, purpose of study, why is the study being done? The study was conducted to determine how many times children with specific language impairments need to be exposed to new words during interactive book reading in order to learn them effectively. Previous research showed that children with SLI typically need 2 to 3 times more exposure to a new word than their typically developing peers. Because vocabulary growth in early childhood strongly predicts later reading success and academic achievement, the authors aim to find a level of treatment intensity that could realistically accelerate word learning for these children. What is the statement of purpose? To identify an adequate treatment intensity, i.e., number of exposures of interactive book reading needed to kindergarten children with SLI to determine new vocabulary words, and to examine which children do or don't respond to that treatment. Rationale for this study. What led the authors to pursue this study? Children with SLI make slower progress in word learning, and this weakness often continues to affect literacy and language development. Although interactive book reading has been proven effective for typically developing children and those from low-income backgrounds, its impact on children with SLI has been inconsistent. The authors wanted to test whether increasing the intensity of exposure could improve learning outcomes for children with SLI, given that they may need significantly more practice to encode and remember new words. What isn't presently being done clinically that led to this topic? Interactive book reading is already used and has good evidence for typically developing and low SES kids with socially low economic statuses. For kids with language impairments, the results are weaker and inconsistent, and nobody had really tested what intensity is needed for SLI. Most vocabulary intervention studies for SLI weren't randomized and didn't fine-tune dosage. What new information did the authors feel was worth studying? The study introduced a Phase 1-2 escalation design, a method adapted from medical research to behavioral language treatment. This design allows researchers to gradually increase dosages, in this case, word exposures, until they find an adequate intensity, where increasing exposure no longer improves learning. This approach had not been applied before in speech-language treatment research. In addition, the authors examined whether children's pre-treatment skills like phonological awareness, vocabulary, and memory could predict who would respond to this intervention, which could help clinicians tailor therapy in the future. Method for the study. Who were the subjects and were they appropriately chosen? The study included 27 kindergarten children with SLI, aged between 5 years, 0 months, and 6 years, 5 months. All children had normal hearing and nonverbal cognitive skills, but scored below the 10th percentile on language and vocabulary measures, such as the Clinical Evaluation of Language Fundamentals, 4th edition, and the Diagnostic Evaluation of Language Variation. This ensured that participants genuinely met the criteria for SLI. The sample included both boys and girls and represented a range of racial and socioeconomic backgrounds similar to the surrounding community in Kansas. Overall, the participants were appropriate for the purpose of this study. What were the subjects asked to do? Children participated in a one-on-one interactive book reading sessions where an adult read storybooks that contained 6 pre-selected target words. During each session, children heard each target word several times before given a child-friendly definition, a synonym, and a context sentence, supported by colorful pictures. The children were also asked to complete a definition task, explaining what a word means, and a naming task, recalling and saying the word when shown a picture, before, during, and after treatment. How was the study performed? Participants were randomly assigned to one of 4 intensity groups that differed by the total number of exposures each child received to each target word. 12 exposures based on prior research with typical children, 24 exposures, twice the typical amount, 36 exposures, 3 times the typical amount, and 48 exposures, 4 times the typical amount. Sessions lasted about 20 to 30 minutes, 2 to 3 times per week, and were conducted individually in quiet locations such as schools, homes, or libraries. Treatment fidelity was extremely high, over 99%, meaning the research assistants closely followed the scripted procedures. The researchers then compared children's word learning progress across the different intensity levels to find the adequate point where increasing exposures stopped improving results. Results of the study. What were the results of the study? The findings showed a clear pattern. 12 exposures were not enough. None of the children learned the words at that level. 24 exposures led to moderate improvement. 36 exposures produced the best results. 43% of children reached the definition learning goal, 5 or more correct definitions. 86% reached the naming goal, 4 or more correct words. Increasing exposures to 48 times did not improve learning and slightly decrease success rates, suggesting that learning had reached a plateau. In addition, the researchers found that children with stronger phonological awareness, better vocabulary, and better non-word repetition skills made greater gains. In contrast, those with weaker scores in those areas were less likely to benefit, regardless of exposure intensity. Did the authors find what they thought they would? Yes, for the most part. The authors predicted that children with SLI would need higher intensity than typically developing children, and that improvement would level off behind a certain point. They were correct. The adequate intensity was 36 exposures. However, the overall learning gains were smaller than what they had hoped, especially on the definition task, showing that this treatment still needs some improvement and refinement. Discussion of the study. How did the authors explain the results? The authors explained that children with SLI require significantly higher input to learn new vocabulary. However, simply hearing the words repeatedly is not enough for many children to form strong word meanings. The current treatment focused entirely on receptive learning, which is listening and observing, which may not fully engage the memory and retrieval processes that support long-term word learning. They suggested that adding active retrieval practice, where children are asked to recall or use that word, could lead to stronger outcomes. Didn't they find what they expected? I mean, why didn't they find what they expected? They successfully identified the correct range for treatment intensity, but the modest results showed that SLI involves deeper learning difficulties than just needing more practice. Children with SLI may struggle to encode or store new word sounds and meanings because of weak phonological awareness and working memory. The demanding outcome measure, definition scoring, may also have underestimated what children actually learned. Therefore, even with adequate exposure, additional supports may be needed to boost retention and generalization. Clinical implications. What are the clinical implications? So, children using interactive book reading with children who have SLI should plan for a much higher number of exposures, around 36 per word to see meaningful learning. 12 or even 24 exposures are not enough for this population. Additionally, clinicians should recognize that some children with very low phonological or memory skills may not respond well to the receptive-only format and may require more direct, individualized instruction. What do the results mean to me clinically? The results show that the one-size-fits-all approach does not work for all children with SLI. Clinicians should monitor progress closely and differentiate instruction based on each child's abilities. For example, children with stronger phonological awareness and vocabulary may benefit from standard interactive book reading, while those with weaker skills may need extra support in breaking down sounds, practicing pronunciation, or repeating the words across different contexts. How will I apply or transfer this myself? In practice, I might choose fewer target words per session, but provide more repetitions of each word. I would combine listening activities with active practices, such as having the child name, define, or use the new word in a sentence. I would use frequent progress checks to track which children are benefiting and which may need a different strategy. I would also incorporate phonological awareness and memory exercises alongside vocabulary instruction. Limitations of the study. The number of participants. Only 27 kids total participated in this study, and only 5 to 7 per intensity level. It was a small sample, so results may need confirmation or a bigger sample size, especially since it only happened in one geographic area, which was Kansas. Other factors. So kids were seen in real-world places, schools, homes, etc., so other language input could have influenced them. So this means that since these sessions occurred in natural settings, other factors like teacher input, caregiver language exposure, or outside reading could have influenced learning. Additionally, the study tested only one type of interactive book reading, focused on listening, and didn't compare it to approaches involving child responses. The primary outcome measure, definition task, may have been too difficult for young children, underestimating progress. Future research. How could future research be done differently? So what I would do is compare two versions of the treatment. One that is receptive only, listening, and another that adds retrieval practice, having the child recall and say the words. Keep the total of 36 exposures, but test different ways to space them, such as having more exposures per session or spreading them out across more days. It should also include more participants to make results stronger and to better understand how factors like phonological awareness, vocabulary, and memory predict improvement. I would try the treatment with children who have very low phonological skills, using a simpler or more direct vocabulary approach that relies less on memory and more on explicit teaching. I would conduct a larger phase 3 randomized trial now that 36 exposures has been identified at the adequate intensity to confirm the findings and test how well they apply in real classroom or clinical settings. So, in summary, the study provided the first clear estimate of how intensive interactive book reading should be for children with SLI, about 36 exposures per word. While the treatment helped some children, success depended heavily on each child's phonological and vocabulary skills. The study shows that therapy intensity matters, but effective learning also depends on how that intensity is delivered and who receives it. Thank you for listening.